p.m. Eastern Time, and we're live here with Dr. Milind Desai from the Cleveland Clinic. Welcome to the program, Dr. Desai.
Hey, Lisa, thank you for having me here, and everybody joining us on Facebook Live on this website. Thank you so much for joining. Hope everybody is staying safe and healthy through these challenging times. But as is become my favorite thing to say, this too shall pass.
Yes, it shall. Today, we're going to have an interesting conversation. We're going to talk a little bit about the Cleveland Clinic team and how it's changing over time. And we're going to talk about all things COVID, what's going on in these COVID days. And then we're going to dig into some articles about risk assessment for sudden cardiac arrest using different imaging modalities. And to some people, this might be a pretty dry topic. To me, I think it's pretty cool because imaging and HCM are like peanut butter and jelly. They just go together. So we're going to work on that. So first of all, Milind, tell us what's happening at the Cleveland Clinic. The HCMA has had a 24-year relationship with the HCM program at Cleveland. How is it evolving?
So I think, the Hypertrophic Cardiomyopathy Center at the Cleveland Clinic has never been stronger, bigger, and it continues to have an extremely robust relationship with HCMA, which has evolved very, very impressively over the years, thanks to, in large part, to Lisa's effort. As there's one thing that's constant in life, and that is change and evolution. There is not really much of a change as much as many of you have come to recognize and love Dr. Harry Lever, who is still going strong with everything that is going on. But earlier in the year, he decided to sort of transition into a role of mostly as a clinician and a less administrative, etc. stuff. He's still doing hypertrophic cardiomyopathy clinics. He's still seeing patients. He's still as engaged and as animated as ever. I am now the director from an administrative perspective. I'm the director of the Hypertrophic Cardiomyopathy Center, essentially, to establish and going forward the academic, clinical, and the research mission of the Cleveland Clinic as a whole, as well as of HCM Center. So from a patient perspective, especially as it relates to Harry, there's nothing that has changed. As simple as that, at least in the foreseeable future. There's nothing that has changed. We have a broader group of providers that constitute the HCM umbrella. So there's myself, there's Dr. Thamilarasan. We are gonna have a new sports cardiologist join our team in the next few months. He also has Dr. Michael Emery. He also has an interest in hypertrophic cardiomyopathy. We have a young multimodality imaging trained Dr. Chadi Ayub. He's joined us from Mayo Clinic a couple of years ago. He's expressed interest. He's getting involved. We have Zoran Popovich, who's also an imaging wizard as it relates to echocardiography. So we have a large team. We continue to have a couple of surgeons. Of course, a lot of you guys know Dr. Nix Madeira, who remains at the top of his game. There's Dr. Per Vierup. He has joined us a couple of years ago, 2-3 years ago. He came to us from Sweden, and where he was doing a lot of myectomies, and he's hit the ground running and doing a lot of good things. Our interventional program is very robust with Samir Kapadia, who is now also the chairman of cardiology. Amar Krishnaswamy is the section head of imaging, of intervention, and our electrophysiology and the genetics program. We are strengthening our genetics program in the next few months, which it seems the world has gotten to a temporary forced vacation, thanks to this little virus thing that is going around. But, from our perspective, the life, at least if you are a sick patient needing care, life is going on. I was, just before the chat went on, I was talking to Lisa. just yesterday I got a call about a sick HCM patient, and rather than dilly-dallying, she is actually here today, and I'm going to see her tomorrow in clinic. And if she needs something done, she's going to get something done in the next few days. The mission goes on. And right now, to be very frank, a hospital like the Cleveland Clinic is probably a lot more cleaner. The heart hospital part of the Cleveland Clinic is probably very isolated in the sense that it is as safe as it has ever been, and you see a whole heck of a lot of people walking around in masks and all kinds of funny looking masks and standard masks. But it is what it is. We are all living in interesting times.
So we're able to see patients virtually right now, but if there's a real need, they can get in.
Absolutely. So, I mean, it is amazing how the business of telemedicine has gone on a state of hyperdrive, insane hyperdrive. I mean, I gotta tell you, in February, if you had talked to your favorite Dr. Lever about virtual visit, right now he's doing virtual visits. I mean, this is crazy. Harry's doing virtual visits. All of us are doing virtual visits. So it's been a great addition. We've learned things along the way. We've learned things how to adapt and manage, and do like a visual physical examination by the patient could be sitting in. I mean, the other day, Monday, I did an examination of a guy sitting in Hollywood, California, with hypertrophic cardiomyopathy, and he was showing me all his physical signs and this. I mean, so we have learned a lot of things. But the most important thing is, if you need actual care that requires interaction, at least our place is open. And we will find a way, and we are gonna ramp it up as the days go along and the weeks go along.
That's really good to know, and I'm sure that everybody who's watching is really happy to know that the program is good. Harry is still an integral part of the program, but we're moving forward, and time moves on, and things are going to grow and change, and that's a good thing. I can remember when you were the new guy, and Harry said, I think he should come out to one of your meetings, which was probably a decade ago now, maybe even a little bit more. And I'm like, wow, we really do have to start thinking about succession planning and how to make sure that we keep these programs that have really good histories, growing, and we build off of that. We don't just let things fall off. So that's really great news. And as always, I'm always happy to work with the Cleveland Clinic. You guys have done amazing work for our population for all these years, and we'll continue to work together. Today, we're going to talk about two articles that you published pretty close in succession, and they're both about using different imaging modalities. I have put the links here on the website or on the Facebook page back to copies of the articles that are now housed on the HCMA website. One of the articles was for a journal called Heart, and the other was for a journal called Circulation Imaging. They cover a lot of the same topics, but they do it a little bit differently. So I put both of the articles up. But why don't we talk for a minute about why imaging is really the foundation of all things HCM?
So thanks, Lisa. Hypertrophic cardiomyopathy over the last 50, 60 years, it has evolved tremendously. As all of us know, we understand so much more about this, and we continue to evolve our understanding as the years have gone on. Like you mentioned, imaging and hypertrophic cardiomyopathy are sort of like peas in a pod, or peanut butter and jelly. I mean, they go hand in hand. I mean, our understanding of HCM has tremendously been improved, vastly enhanced because of our improving expertise in imaging. I mean, there is no denying the fact, the SAM, the mitral valve problems, the gradients, the murmurs, the just the physical appearances. Some of the things we have learned in the last decade and a half have been tremendous, and a lot of it has been helped by imaging. A lot of it also, imaging has helped understand the disease, but also help clear up some dogma, some this is how it is. Not really. It is not always like that. There are some nuanced thinking. What it does is it adds nuanced thinking. It is not, it is showing us it's no longer black or white. There are maybe 48 shades of gray here before it goes from black to white. So, but it is, but we are living in exciting times, and a lot of stuff is happening in HCM in general, but imaging, genetics, multi-center trials, drugs, a lot of centers are coming together and recognizing that it is important to do research in a collaborative way. So the next, the last decade was sort of, the teenage years, and now you are entering into real adulthood. I mean, you're going to see a lot of defining things for our generation coming out in the next 5 to 10 years. And this is an exciting time to be a practicing physician interested in this disease, but more importantly, the patient.
So I'm going to pause for a second and use some of my own terminology. When explaining different areas of cardiology to patients when they call the HCMA and they say, well, I saw this doctor and he's an interventional cardiologist. I'm like, well, we need to take a step back because interventional cardiologists intervene. They do things. Surgeons do things. They do surgery. Electrophysiologists work with the electrical system, the conduction system of the heart. And imaging cardiologists are what I refer to as the map makers. You have no idea where you're going until you have a really good map. Mm-hmm. And that is what imaging helps us develop, is that map of the anatomy. So let's jump in and talk about what the imaging technologies are, the differences between echocardiography and MRI, because those are the two main areas of imaging. So why don't we talk about what you get out of each one?
Yeah. So, obviously, as Lisa mentioned, these two are the most commonly utilized modalities as it relates to working up a patient with hypertrophic cardiomyopathy. Now, there are other techniques also. Nuclear cardiology has a small role in some cases. In occasional cases, the CAT scan may also have a role. But the two 600-pound gorillas in the room are echocardiography and CMR, cardiac magnetic resonance, or cardiac MRI. Now, echo has been used for generations now, or for about 40, 50 years. And echo is not one all be all. It's a series of things that come in full. I mean, once you do a series of things to generate a final echo report. And what happened when I was in first grade is not how we do echocardiography right now when my child is an undergrad in college, right. So it has also evolved. So echocardiography obviously it utilizes ultrasound and a skilled sonographer to acquire images of your heart, where you can look at the thickness of your heart, you can look at the valves, you can look at how the valves are causing obstruction to the flow of blood, you can look at how, if the valves are leaking, you can also have an understanding of how stiff your heart is, what the lining of the heart is doing, what your overall heart function is doing. So echocardiography is the gold standard and is the first step for assessment. And echo is extremely well suited to assess hypertrophic cardiomyopathy, as it gives you a full picture of everything you need to know. So one is, if there are some of my patients on the call, they would recognize when I talk to a patient, I talk about HCM in the following bins. One is you have to establish the diagnosis. Occasionally, we have to confirm the diagnosis that somebody has given. Then ascertain the severity of the disease. Then, how the heck are you going to treat this patient? Is this a drug? Is this a surgery? Is this something else? Is this require a pacemaker? What is it? Then comes, what are the lifestyle modifications? Not everybody gets the same advice. Then comes, what are the implications for family? Do you have somebody where I need to raise a 9-alarm fire right now? And then comes basically, what do we do about risk stratification? What is, you are the patient. What is my risk in the next 5 years of dropping dead from an arrhythmia or hypertrophic cardiomyopathy? So these are some of the things that you are looking at when you are evaluating a patient with HCM. And echocardiography helps identify, it's the first gate point. It gives us a full spectrum. Now, over the years, what we have learned is that echo is excellent, but there are certain nuances where echo can be used, but there is a need for some more precision.
I'm going to
Looking
pause
at,
you there for a second.
yes.
And everything you say, I 100% agree with. But there is a difference between a center of excellence, high volume HCM programs, echocardiogram, and the echocardiogram that you get at the doctor's office down the street. Is there not?
Absolutely. Absolutely. Like everything else. I mean, yes, absolutely. You can get a burger at a burger joint and you can get a burger at a high-end place. Of course, there's a difference. And a lot of it is experience. A lot of it is recognizing and anticipating what you are getting or what you need to be getting. So absolutely could not agree more. And nowhere it is true than in hypertrophic cardiomyopathy. A well-done HCM echo, often I joke often, and that drives some of my colleagues crazy. I mean, right now, with the expertise of sonography at the Cleveland Clinic, if I were stuck on an island with an HCM patient and I have to decide what I need to do with that patient, all I need is an echocardiogram and a good sonographer. Mm-hmm. I can answer most of my questions. So having said that, we all live in a real world, and in the real world there's heterogeneity of acquisition, of quality, of the data that is acquired. Doesn't mean that people have a malintention. It's just that, in a place like this, we may see 40 HCM patients in a fortnight. In some other places, they may see one every 6 months. So the expertise is different, and you have to roll with the punches. So that is where the recognition of that is crucial. Now, you asked me a question of comparing MRI to echo. So MRI, I will say, is not a replacement for an echo. It's an adjunctive test to echocardiography. By that, I mean you get the echo and then you get some additional information using MRI. So what are those additional things? You can get more precision in terms of wall thickness and where the hypertrophy is, what is the association of the mitral valve and the papillary muscles and all the things, number one. The other thing, I will say echocardiography is sort of like Star Trek. MRI is like Star Trek. It boldly took us where we never knew to go before. It has taught us like apical aneurysms. We have looked at new phenotypes. A lot of this, you would hear me talk about papillary muscles and mitral valve and the apical aneurysms and the thrombus in the apex. All those things, it's not like they started developing just 5 years ago. It's just that we are now recognizing more and more of that because we are doing some of these advanced imaging testing. The additional thing that MR does better than echo is it can ascertain the amount of fibrosis or scarring within the myocardium, within the heart muscle. And you can quantify that. And there's emerging data that shows that the higher the scar burden, the higher the risk of you having an arrhythmic sudden cardiac event. And then there's some newer stuff that is happening that people will be reading about, where you can not only look at the discrete scar, but you can also look at diffuse scarring. There's something called T1 mapping that a lot of folks have a lot of excitement in. So all these things, adjunctive stuff. So if you have echo and MRI, you have the full package in a given patient, which can help us so much better refine potentially the risk for a future event, number one. And number two, plan a procedure to help you right now with your symptoms.
So looking at the articles that you've just recently published, you talk about, trying to better understand these risk factors for sudden cardiac arrest while using imaging modalities. And the team that you worked with on these documents really did some great research and pulled out old data and looked at all these comprehensive evaluations done and tried to make sense of them and look at the commonality and the gaps. And when we're doing research, it's great to know what we all agree upon, but it's also really important to know what we haven't delineated yet. And there's a difference between the American version of risk assessment and the European assessment of risk. And they differ, and a lot of it is differed based upon imaging and what we know. So, can we talk a little bit about the association of particular anatomy or things that we can identify with imaging that lead to a higher degree or higher percentage risk of cardiac arrest? And then let's talk about how they balance between the American version based on guidelines and the ESC risk score, which is based on some factors that were put into an algorithm that come up with a percentage score.
So, yeah, I think that is crucial. And the older I get, I got to tell you, Lisa, the more what you call crankier I get when I'm evaluating data. And the more it's like, you know what? Not everything is black and white. There's a story to every story, and there's an inside story to every story. So, imaging, like you said, is crucial in all these things. So one of the biggest risk factors that everybody has heard is, the thicker your heart, the worse off you are. Otherwise, if your heart wall, your left ventricle wall, any part of your LV wall, left ventricular wall is more than 3 centimeters, 30 millimeters, that's a major risk factor. You should have a defibrillator placed. My God, that is a big deal. Now, 30 millimeters, that's fine and dandy. Where did that number come from? Why not 27 millimeters? Why not 28 millimeters? To me, it's a continuum.
It is, yeah.
It's a continuum, number one. Number two, these data, the original data, were derived from echocardiography. And anybody who reads echoes, myself, or looks at echoes at any, the difference between 29 and 30 or 28 and 30 could be a semi-careful sonographer. The keyword is semi-careful sonographer. So, it has to be very precise. And within the heart, there are some trabeculation. It's sort of like you are in a ravine and there's some crevices. So do you include part of it? Do you not include? What happens if you do? What happens if you don't? So measurement of wall thickness is precise, but it's not that precise to be able to differentiate between 30 and 32 millimeters. In fact, so that is one of the shortcomings of echo. That's where, CMR, MRI can be helpful. Because MRI, it has better resolution and you can better recognize the delineation of what is wall and what is trabeculation or those crevices. Now, I will tell you, so we did a paper a few years ago where all the patients had a transesophageal echo where a probe is passed down your throat. They all had a surface echo and all of them had an MRI. They were undergoing evaluation at the Cleveland Clinic for surgery. And what we found was the numbers are fairly off. The numbers tend to be different for different modalities. So which one is right? If you use MRI as a gold standard, then echo looks not so good. If you use echo as a gold standard, then MRI looks super good. I don't know. Now, another thing that the my good friends at Mayo Clinic, they published a few years ago, what they did was interesting in the sense that they took group of HCM patients at two different ends. One is at 15 millimeter wall thickness, and the other one is at 30 millimeter wall thickness. Why 15? Because that's the diagnosis cutoff, meaning if you are less than 15, you may not have HCM. If you're more than 15 millimeters, you very likely have HCM. And 30 millimeters, 28, you don't get an ICD. 32, you get an ICD, a defibrillator. Now, what they found was these two areas were the areas where there were the biggest errors. Echocardiography was not the most sensitive in terms of of delineate. So imagine you are a patient sitting, forget Milind Desai, the researcher. I'm your cardiologist. I'm looking at the data. Doc, is it 15 or 17? Oh, I don't know. Is it 14 or is it 32 or 30? Oh, I don't know. I hope the sonographer was not half asleep when they were doing the measurement. So, this is something which is where you have to take it with a grain of salt, which is why when you are looking at a patient, you have to look at the full picture. You cannot just stick to a given number. This is one of the important things. And the other aspect of wall thickness is, what if the thickest segment is not in an area which is very easily visualized on echocardiography?
Exactly.
You're screwed. If you're a patient, you're screwed. I don't want to be that. So that's where CMR, MRI essentially helps. There are no boundaries. If you are able to tolerate an MR machine or a CAT scanner for that matter, we will know where your maximal thickness is, and we can calculate mass, we can be very precise, etc. So that's an important thing. So that's one aspect of imaging that I wanted to. The other is, as I alluded to, a lot of people talk about apical hypertrophic cardiomyopathy. And for years, it was thought that people with apical HCM were lower risk than the standard HCM people.
And it was rare.
And it was rare. Yes. So quotation. Well, guess what? Once we started looking at things in earnest, it ain't that rare and it ain't that low risk. And we have found new things like, a lot of these folks have all the way towards the bottom of the heart, a small outpouching we call that a small apical aneurysm. And the folks from Tufts University, they have demonstrated that people who have apical aneurysms, their risk of a cardiac event in the future is much higher than if you do not have an aneurysm. This, so this is new information that clearly, how did we stumble upon apical HCM and the aneurysms? I mean, it's not like they were non-existent. They've been there forever. It's just that we are doing better imaging. And even with echo, people are now more tuned in to be looking for that. So in our lab, they know if it's a Desai patient and if it's an apical HCM, they better get a contrast agent. Otherwise, I'm going to send the patient back. Why is that? Because the contrast helps delineate better. It helps us. It is more sensitive. More importantly, they know how to adjust the scanning to get a better echo image. I will tell you, using multimodality imaging has substantially increased the skills of our sonographers, because people like me go back and give them feedback, and when they get the feedback, they understand to do things better next time. The other aspect I would like to talk about is, the scar. A lot has been written about scar that you see on MRI.
Yeah.
Echo doesn't see that clearly. Okay, but so what? You can haul an echo machine to the emergency room. You cannot haul an MRI machine to the emergency room. So there is advantages to each technology. But be it as it may, CMR is uniquely suited to be able to look at quantified scar. Now, a lot of stuff has been written. We have published data. The folks from Tufts University and Toronto, they have published the data that you can quantify scar, and then you can establish a threshold beyond which, if you have more scar beyond that certain threshold, your risk is higher, could be twice as high. And this is important information. However, what is also important to know is, how did Milind Desai's laboratory measure the scar versus the Tufts laboratory measure the scar? The number will be different depending upon the thresholding you see. Okay, it's like your TV screen. If you turn the color gain too bright, then everybody looks like they put red makeup on. If you put it too on the other side, then you appear darker. So that's another. So you have to establish a threshold, a uniform threshold beyond which, and everybody has to agree upon it. If you don't agree about it, I mean, then, if Lisa does her analysis one way, I do my analysis, then the numbers are going to be different. The advice is going to be different. So just because you had an MRI doesn't mean that everything is hunky-dory. There needs to be certain agreed upon rules, certain thresholds, which help us identify the risk thresholds. Now, an important thing that is going on, and many of you may have been part of it, many of you certainly have heard about it, is this trial called HCMR Trial. This is an NIH-sponsored trial, and 40 countries in North America and Europe have contributed almost 2,800, about 2,750 patients or thereabouts. That's a huge number. Patients have, across the board, across all these countries, echoes, MRIs, genetics, other blood draws, and we are following these patients for about a 5-year span. That will help us. Papers are starting to come out of it. That will help us understand the existing risk factors, the newer, the semi-existent risk factors, and brand new risk factors that we've not even thought about in the clinical realm right now. So, as I said, the future is tremendously exciting. Now, the issue, but we have to realize everything, MRI is great, but you need to know what you're doing. Echo is great, but you need to know what you're doing. Another thing I want to talk about, which is very important, is outflow tract gradient. Okay, so a lot of you live and die by your outflow tract gradients. You heard about SAM, systolic anterior motion. You heard that one of the things that happens in HCM is there's obstruction to the flow of blood, and the pressure difference from beyond the aortic valve, the pressure difference is what we call as outflow tract gradient. And this tends to be dynamic, meaning you can be sitting here listening to me, and you may have no gradient. If I say something that you don't like and completely excite you, your gradient may jump up to 100 millimeters of mercury, okay, which is severe. So it is absolutely.
Let's go back on that one for just a second.
Yes.
A normal gradient is 0. You should
normal is
have
0.
Any pressure gradient. A little gradient is under 30.
Yes.
And then over 30 to 50, it's in that area where we're paying attention. Over 50 is where, if you're symptomatic, that's when you go to myectomy or alcohol ablation.
Exactly. Houston, we have a problem beyond 50. But the number of patients, the proportion of patients that have a resting gradient that is considered in the severe range or more than 30 millimeters is about 25%. But in an experienced center by an experienced sonographer, by an experienced team, if you are looking at it carefully, that number can jack up to about 70%, 25 to 70%. So the patient could be short of breath. You go to an echo place, they do a simple echo. Oh, you have nothing going on. Your gradient is 22, but you still are short of breath. They do not do a full-fledged examination. You come to a place like me. We do an examination. We do a thorough evaluation. Your gradient is 100. Now we connect the dots and we do the right treatment. So it is crucial. It is crucial that these gradients are done well and by experienced people. And a lot of times you can also, the signals, the echo signals can be overlapping. So you could have a mitral valve leak and an outflow tract gradient. They sit one on top of each other, and you have to be able to recognize which one is which. Otherwise, you will overestimate a problem and freak somebody out, or underestimate a problem and give somebody a false sense of security. So these are some of the important things that we need to look for. The other thing that Lisa mentioned, and I'm going to tie everything up, is the European score talked about left upper chamber size, so left atrium. They utilize a formula. Within the formula, you can incorporate what your left upper chamber size is. And now, that is one parameter that I'm the least sold on. As a guy who does imaging and a whole lot of other things, that is the least reliable at least on echocardiography. And if you are using it as a continuous variable, if you are using it as an absolute number, today you measure 4.2 centimeter. Tomorrow you measure on the same thing 4.6 centimeter. So then the numbers can change. So it is important to know what goes into the sausage before the full sausage is made. So that is, as a consumer, you need to understand exactly the pluses and minuses, and you got to hold your physician accountable. Or got to make sure that they listen to they take all these into consideration.
In my experience, and I come at it from a different point of view than a clinician, I find left atrial dimension helpful to determine risks of atrial fibrillation.
Yes.
And are we getting to a point where that left atrial just can't be compliant anymore? But to equate it to a risk factor for sudden death and arrhythmic death, I've had a problem with that as part of the ESC score for a long time, and I don't see a lot of justification in the literature that it is an independent risk factor for sudden death.
Yeah. I mean, so the way I look, Lisa, my opinion, and I know this is Cleveland Clinic opinion, there's some conversation about atrial fibrillation. To me, in a hypertrophic cardiomyopathy patient, if he or she goes into atrial fibrillation, that bothers me a lot. That to me tells me that this person has moved into a much more higher risk category than they were.
But is it risk of sudden death or risk of heart failure?
It is a risk of badness, not necessarily sudden death, but it is a risk of badness. Okay, it tells me that you are behaving like your heart is behaving like a bad actor. So for example, if you are a short of breath patient with outflow tract obstruction, your gradient is 100 millimeters of mercury, and now you go into Afib, I can tell you, you may have been chugging along. Now you ain't gonna. You are not gonna be chugging along. You're gonna be going. So to me, that is an important distinction. So coming back to closing the loop about the two ways of the North Americans and Europeans have differences of opinion in more than one scenario, not just hypertrophic cardiomyopathy. So of course I'm not surprised. Hypertrophic cardiomyopathy also, there is a conversation difference. But in North America, what we do is, you have a family history, you have a history of sudden cardiac death, you are passing out unexpectedly, your wall is thick, you have scar, you have an aneurysm. If you have these things, then we tabulate a score and utilize clinical judgment in recommending whether or not you have a defibrillator, you need a defibrillator or not. In the ESC score, what they do is they take absolute numbers and you put it in a formula. So the numbers involve left atrial size, outflow tract gradient, your age, whether or not you passed out, etc. Now, outflow tract gradient, I can tell you, if you are coming to see me in the office and I've had you eat or drink nothing since midnight, your gradient at 8 o'clock in the morning may be higher than after a reasonable amount of hydration. So the gradient is called dynamic gradient for a reason, because it is dynamic. It is like my wife's mood. It changes from moment to moment.
You're going to get in trouble on that one.
Yeah. So, so how do you put it in a formula? And then the formula for somebody like you could change from 8 o'clock in the morning to 4 o'clock in the afternoon. Same way with left atrial size. How do you put that? Septal, wall thickness. How do you, because if you measure it right, then it works. But how do you know you measured it right? So
you mentioned something about septal measurement, and I'm going to pull you back to that for a second. And when sometimes we use the word septal measurement, it doesn't actually have to be septal measurement. Yeah. It's anywhere in the left ventricle. So
anywhere in the left ventricle.
Posterior wall, free wall, apex, septum. I often go like this when I'm talking to people on the phone, saying like, this is your septum, this is your apex, this is the free wall. Any area of that letter U can be thickened, and thereby that's the problem. Wherever that is thickest, the number we're looking for. So the tricks between MRI and echo For one, are how you measure that outside wall. You can shoot through that when you're doing an echocardiogram, and you can think it looks normal, but when you do the MRI, you actually realize it's a lot thicker than you thought, because when you're doing the ultrasound, you shoot through it, and thereby you might not get an accurate number, which that's where they enhance each other.
Yeah.
We've been asked a question in this chat. Why don't we just do MRIs?
Yeah.
Number one, they are more expensive. Number two, they are more time consuming, and there's less resources to do them because they take longer. They take good 45 minutes to an hour to get one done, and a big piece of technology.
Yeah.
An echocardiogram, and I want to spend a few minutes on this one because this gets into another question. Well, if echo is how you diagnose HCM, shouldn't everybody get an echo all the time, no matter what, HCM or not? And then you get into the question of quick screen echocardiograms. Has there ever been a validated quick screen echocardiogram to detect hypertrophic cardiomyopathy, Dr. Desai?
The answer is no. A quick screen echocardiography sounds enticing, but as I said, I mean, look, never say never. Technology is rapidly evolving. There is something called point of care ultrasound. Okay. Right now, we are living in the era where everything is done virtually and remotely, and point of care this and point. Nothing like a virus to start to have people start questioning everything we do in life. So never say never. But as of right now, we do not have a study where we can do a quick echocardiogram. Yes, a quick echocardiogram done by an experienced person can identify somebody potentially who could require the full echocardiogram. The way I look at it is, if you are a suspected patient of hypertrophic cardiomyopathy, at the end of the day, all these quickie things at the very best should do is to get you in, but you really need a thorough evaluation by an experienced provider, because there's nothing worse than giving somebody bad advice. On either end of the spectrum, if you have HCM and I tell you you don't, I'm doing you a disservice. If you don't have HCM and I'm scaring the living daylights out of you by overcalling you, then also I'm screwing up your life. So, all these quickie evaluations should typically, unfortunately, what ends up happening is a lot of people who do these evaluations are not experienced enough, and they will scare the living daylights out of you. And then you end up spending a lot of time in angst before a reality. I mean, one thing I will tell you, 2 or 3 of the most common diagnoses, and Lisa will attest to it, 2 or 3 most common diagnoses that we have before somebody makes a right diagnosis of HCM is, you have asthma. Oh, it's just a benign murmur that everybody, young children have it, or you're crazy. These are the 3 most common diagnoses before somebody real. I've had grown men cry in my office when they are crying because finally they have an answer as to why they are feeling the way they are. And they've been trying to convince somebody for years. So, I have nothing substitutes experience in all this. So, yes, the world should evolve towards doing quick this and quick that, point of care ultrasound and point of care this and point of care that, but nothing beats experience. The person who is interpreting the data should know what he or she is doing. Cannot underscore the importance of that.
Absolutely. So the topic of these, these topics of these articles were how to use imaging to help delineate cardiac arrest risk. In a nutshell, what have we learned about what imaging features do lead to a higher degree of risk of cardiac arrest?
So, yes. So if I am seeing somebody with an extremely thick heart, so before we even go to imaging, I mean, all of us have to be doctors. So if somebody's coming to me and they are passing out unexplained and say, my grandpa died in a farm at the age of 28 with a heart attack, or my daddy was driving his tractor and he keeled over and nobody did an autopsy and they said it was a heart attack. I love this term heart attack in a 28-year-old, unless they were doing cocaine and living it up. I mean, chances are they may have had something else that was not picked up. So, history is crucial. From an imaging perspective, obviously, a very thick heart. If I'm going to see something thick, I mean, clearly 3 centimeter, 4 centimeter, that's a red flag in itself. But, when I'm seeing somebody with 26, 27, 25 millimeters, my antenna goes up. Now, I will tell you, anybody who's my patient knows this. I never rely on anybody else's interpretation. Before I walk into their room, I have measured the thing myself. Okay? I have measured the thing myself. I've looked at the echo, I've looked at the stress echo, I've looked at the MRI myself. So, that is absolutely important for you to, you to be assured of. I do not rely on anybody else's opinion. I make my own. So a very thick heart. If you
very
have
thick anywhere, septum, apex,
exactly,
anywhere thick, over approaching 3.0, approaching.
Yes, approaching, exactly. Okay. The other aspect, if you are, so the syncope or passing out, that's an interesting situation. Okay. If you're passing out with exercise, or you're doing something and you're passing out and you have a gradient that is severely elevated, to me, that is going to make me drive more towards a fix, a surgery, or in occasional cases, I'll call septal ablation. There's not enough blood going out. Of course, you're going to pass out. There's other aspect why patients pass out, and that is, could this be arrhythmia? Okay, so it is crucial when a person says that they passed out, it is very crucial to ascertain what exactly they could be passing out from. The other, nowadays, MRI, if there's somebody, so a scenario like if somebody has borderline wall thickness, 24, 20, or not borderline, but not reaching 3 centimeter, but let's say 25, 26 millimeters, and they have a lot of fibrosis. To me, that guy is in the same category as somebody who's got 34 millimeter septum. That's clinical gestalt. That's judgment. So my recommendation there, at the very least, I'm going to say, buddy, this is what you got going on. It may be time to at least engage an electrophysiologist, an electrician of the heart. Let's see what he or she thinks. Does he or she agree with my gestalt? Most of the times they don't disagree with what I have to say, but it's always good to have an opinion from them. The other, look, in all fairness, I will say this, in most of my patients, I do calculate both the North American as well as the ESC score, okay? But at the end of the day, I let my judgment, my knowledge, my clinical intuition of the overall picture guide me as opposed to a number, okay? A cutoff of 4.1% risk. In the ESC score, they say if your risk is greater than 6%, you get an ICD. If your risk at 5 years is greater than between 4 and 6%, you may get an ICD. I have no idea what may means, if it is less than 4% in a 5-year span, it is not indicated. Now, I don't know about y'all, but if my family member has a 4% risk and it does not involve scar assessment, it does not involve anything else. If my family member has a 4% risk, 3.99% risk, and a lot of scar in the heart, that person is getting a friggin' ICD. Pardon my French.
You're getting very Jersey on me.
Yeah, exactly. It is. And the other, I see a comment about blood pressure drop upon exertion. So, the blood pressure drop was thought a lot problematic back in the day, but it is also nuanced thought process. If you are exercising and your blood pressure drops by 20 millimeters or does not rise appropriately, but if you have a high gradient, then the meaning is not the same as if you did not have a gradient. So if you are a patient of mine with no elevation in or an abnormal blood pressure reading and no high gradient, then I'm going to take you a heck of a lot more seriously compared to your gradient is 120 millimeters of mercury, because I know what to do there. There, I send you to Uncle Nicholas and he'll fix you. He'll do a myectomy, and that gradient of blood pressure drop will be a thing of the past.
So blood pressure, when the first iteration of the guidelines came out, drop in blood pressure was viewed as a high risk feature. And then we've learned more, as typically happens over time. And the more we learn, it really matters why there's a drop in blood pressure.
Exactly.
If it is related to your gradient, if you're obstructed, most people who are obstructed have a blunting or a drop in blood pressure with exercise. So that has to be calculated. And when we do this comparison between ESC and US, and I don't want to get into a they're better, we're better, and make it an argument, we're all working on an evolution of better understanding. And it would be really nice if I could just go, oh, here's your whole, figures and facts, and this is you, and we can put it into a quantified algorithm and say, this is what's going to happen to you in the next 5 years. It would be nice, but it's not really accurate. And there's been a lot of research done, especially the Marins did a number of comparators where they looked at American guideline scores versus ESC. And it turns out that a large number of those who were viewed as low risk from ESC would have died because they had appropriate ICD charges.
And to your point, that was something I was going to address, to compare the two. Again, we are not living in a I'm better than you world. We should not be, okay? Realistically, it is all of us need to learn. And it's okay to accept the fact that, what our thought process 20 years ago was wrong, and we learned from it. I mean, to not to digress, but when I was in residency, giving hormone replacement was the thing to do in a postmenopausal female. I mean, oh my God, your patient is not on hormone replacement. What kind of a bad doctor you are. Now we know it kills people. Aspirin for primary prevention. Everybody and the grandmother got aspirin. Now it has no data, or the data suggests it's not helpful. So we evolve, If we don't evolve, we'd still have tails and walk on fours. So we have to evolve. And which is where the more we learn, the more we put things in our diagnostic and prognostic armamentarium, and we are going to get better, which is where a trial like HCMR, I mean, what is the, can a Cleveland Clinic physician do, can I do a 2,700 patient study? You darn right I can. Absolutely, Lisa. I can. We can. But that will bring with it our own set of biases, the patients that get referred here, etc. The beauty of this multi-center thing is it represents real life practice, real world practice.
And that's what's key. I mean, any one person can come up with something that works with what you said, all of their biases. We all come with biases. Biases aren't bad. They're just our perspective.
Yeah.
When HCMR, the thing that was beautiful about it is there was multi-center.
Yeah.
You had slightly different technologies that were being used. The MRI machines themselves were different manufacturers in some cases. So you had some variability, and then you put that all together, and then you have the best minds working together to say, I think this, I think that, battling it out and coming up with what comes out to be the best answers for all of us.
I think at the end of the day, that's what it is. I mean, it's not, my technique is more sensitive than yours. And then, no, I think this is not a schoolyard playground. I mean, we are trying to help patients live a normal life and not drop dead before it's their time to check out, and I think at the end of the day, that's all there is to it. I mean, to me, that is it. Nothing else matters in this.
Couldn't agree more. Now, I always look at the conclusions of an article first. I know that's kind of like going to the last chapter and then reading the whole thing. But what you've said in the conclusions in both of these articles are basically that these are all really interesting findings. We still have more work to do.
Absolutely.
And I think that's critical for patients to understand. And I'm actually going to go back and tell a story of one of Harry's old patients. In approximately 2000, he went to see Harry for an evaluation. This was at the start of the use of MRI. So early in the process, we didn't even use gadolinium yet. We didn't understand that we could use gadolinium for this purpose. So the guy had an MRI, got an assessment, and it was, you have good old-fashioned HCM, check in with us every few years. Here's your exercise modifications. Here's some medication. Have a good life. We'll see you down the road. Well, this guy didn't ever think it was necessary to come back. And 6 years later, he had a cardiac arrest. And the good news and the bad news are the same news. He survived. Yeah. But he didn't survive intact. Yeah. He has serious brain injury. And sometimes there are things that are worse than death. Yeah. And he doesn't remember his family. He doesn't remember anybody. So this has stuck with me for 20 years, this one case. Out of all the families I've worked with, this one's always bothered me. Because just because you go once to a center of excellence and you heard something that they said that day, it changes. It may not change in 6 months or a year, but a year and a half, 2 years, we're constantly learning. We're evolving, we're growing, we're changing, we're reassessing. New patients come in with different presentations, which teach us something, which means you all get to learn from it as well. Yeah. So this is, anybody who knows me, if you've been watching these a while, centers of excellence matter for a reason. There's a reason I've dedicated my life to this mission, because I know what can help patients, because I've worked with these people who are amazing and continue to learn and to push and to grow. And that's how we all benefit. So we have to keep learning, but we've learned a number of things here. MRIs do matter. How you read them matters. Left apical aneurysms matter. Apical HCM is just HCM, ladies and gentlemen. It's just HCM, and it has to be assessed like any other HCM. You're not rare. You're not protected. You just have hypertrophy in the bottom of the heart as opposed to one of the sides.
Yeah, so. Couldn't agree more, Lisa. And you've known me now over the years, and I strongly feel the day I stop evolving, the day I stop thinking, the day I stop, I'd much rather, I'd be on some island just enjoying my life and hoping there's no virus there. It's as simple as that, because we have to continue to do that. And the day my mind gets to a point where I'm always right, shoot me.
Okay.
Real. No, that is terrible. That is a terrible way to think. I learn every day from everybody. And that's the only way to evolve. And evolution is what matters in all these everything. We are living it right now. We are living it right now with this virus thing. So
in 1995-6, when I started the HCMA, the data was pretty consistent that if you were a child under the age of 10 diagnosed with HCM, and specifically if you were an infant born, the data was clear. The mortality rate was ridiculously high and you were not likely to survive. Then we learned about spectrum disorders, that if you had a sarcomeric mutation HCM, which is the majority of HCMs, that your likelihood of survival was excellent and you could live to an average age of mortality. But if you had one of the spectrum disorders or one of the syndromes, this was a different diagnosis. Yeah. Now what's happened? Pompei's disease, one of the spectrum disorders, has its own therapy. Yeah. And these kids can live now. Yeah. And the Dannon's kids are getting therapies, and the other diseases are getting different therapies. So we're learning, and it doesn't mean that what you were told at the time of diagnosis holds true today. So we need to keep evolving, and that's a great thing.
Absolutely. Couldn't agree. Who knows, 5-7 years from now, we will have a streamlined cookbook of bam, 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 bam. This is your risk based on your echo, MRI, stress echo, and this data, that data, and and now we may have drug therapies to treat HCM, not just beta blocker and disopyramide, and we may have real drug therapies for all I know. And so that's why the first thing I said in my conversation with you was we are entering uh, the exciting adulthood of this disease. I think these were just the teenage years. We've explored a lot. We think we know it all, but adulthood is still around the corner.
I agree. I'm just going to go back through here and see if there's any quick questions, because we've kept you quite long here today and appreciate your time. So there was a question earlier on about apical HCM and drug therapy for that. And I'm bringing this one in. It's Kelly's question from the beginning of the session. Well, we can't comment, Kelly, directly on what is in your best interest, because obviously there's a lot of other factors than this one line. I want to talk about apical hypertrophic cardiomyopathy and what steps are next. She's looking at ablation. Can you do an alcohol ablation for an apical HCM?
No. So that, we don't really need research. What ends up happening with apical HCM, as Lisa has alluded to, the thickening is in the bottom of the heart. Okay. And a lot of patients, it's not the obstruction to the flow of blood that is causing their symptoms. The symptoms are due to a very stiff heart, because the heart is very thick. The heart cavity, which stores the amount of blood before it pumps out, is very small. So the stroke volume, that's what we call the amount of blood that is getting pumped out, is small. And there is all these disease of the small coronary arteries that supply the blood to the heart muscles. So most of these symptoms are a combination of these things. So alcohol septal ablation is typically reserved for thickening that is above, closer to the aortic valve, just underneath the aortic valve. Now, so ablation is not going to work in this, but there is evolving technology such that, if we do a myectomy where we are shaving off the muscle and increasing the size of the heart cavity and removing some of the diseased muscle, there is emerging data that this can help with symptoms. And we still do not know whether or not it helps prolong life, but for sure it helps symptomatic improvement. Now, so the folks at Mayo, they have developed a way of doing an apical myectomy where they go through the heart from outside, from here, and create a hole in the apex and burr out the muscle from there and then close it. So they have Dr. Schaff, Hartzell Schaff, who's a great surgeon. He's pioneered that technique, and they've done a few cases. Now, at our center, we've taken a different approach. Look, I'm a simple-minded human being. I don't like a hole in the heart, okay? And neither does Nick's Madeira. So what we've done is we do the approach same way as we would do a myectomy closer to the aortic valve. And what he's starting to do is a deep myectomy. So instead of a small knife, maybe he uses a longer knife, or he goes deeper. But the using advanced imaging and very careful planning, we are doing these extended myectomies deep into the heart cavity with very similar results. Now, I have to admit, and Nick may come after me if he hears this, but for me to convince Nick to take a patient like this for an OR becomes a multi-pronged approach and manipulation on my part. And I mean that in a joking way. But we do an extensive workup. We truly demonstrate that these folks are symptomatic because of that thick heart muscle. And once it is convinced, then we are pretty aggressive in going in and basically what we are doing is debulking the myocardium. We are debulking the heart muscle. We are making the heart cavity bigger so that it can store more blood, so that it can pump out more blood. So, but, ablation is not the answer, but these innovative techniques are. Now, I will say this. I read a paper in one of the journals a few years ago from somewhere in Korea, I think Korea or China, I forget, one of the two places. It was in Journal of American College of Cardiology, where they are using some novel radio frequency ablation
Oh, yeah.
to sort of burn the inside of the myocardium. This is still works in progress. Again, who knows, 5-7 years from now, this is what we may be talking about.
So we brought up the word ablation, which always brings in confusion because there's alcohol septal ablation, which can be used to treat obstruction in a particular region of the heart. And then there are ablations that are done for arrhythmic purposes.
Yeah.
So one of the questions came up, is cardiac ablation effective treatment of HCM? And that's a complicated question.
Yeah.
So the question would be...
But an important question. This question, it has two questions and two answers. So the question is cardiac ablation helpful in hypertrophic cardiomyopathy? So there are two questions. The first question is alcohol septal ablation helpful to relieve outflow tract obstruction in hypertrophic obstructive cardiomyopathy? That's the first question. The second question is radio frequency ablation helpful to relieve atrial fibrillation or atrial flutter in patients with hypertrophic cardiomyopathy? So these are two questions. And the answer is yes and yes, but with a twist. So alcohol ablation is in careful hands and careful providers and careful clinicians. It can be used to relieve outflow tract obstruction. And in many scenarios, it could serve the same purpose, albeit differently, similar to a surgical myectomy. Essentially, the whole concept is you have to remove the thick part of the septum away from the mitral valve. You have to separate your mother-in-law and your wife, the wife and the mother-in-law away from each other. So, myectomy, it just removes one and places them away. So it shaves the muscle off. Alcohol ablation, it squirts some alcohol in one of the blood vessels supplying the upper septum, which then ultimately results in shrinking of the heart muscle, and again serves a similar purpose. Now, I think the nuanced discussion about which one is better, it's for another day. We are not going to go into that. But be it as it may, in the rightly selected patient, it can do very well in helping these patients. Now, the other one, the Afib ablation or a Flutter ablation, that's a different thing done by a different set of providers, by the electrophysiologist, where you radio frequency ablation in the left upper chamber of the left atrial wall, and you create burns. Now, one thing we've learned over the years is if you have Afib in hypertrophic cardiomyopathy and you need an atrial fibrillation ablation, the success rate is not as high as it would be for a standard non-HCM Afib patient. The success rate here is generally quoted to be about 50-50. I personally think it's even lower than that.
I go 40.
Yeah, exactly. It is even lower than that, but that's okay. 30, 40, 50, but it's not 100%, it's not 80%, it's not 90%. Flutter, on the other hand, if you have Flutter is typically a single circuit causing a problem. So the success rate for a Flutter ablation is much higher than Afib. But these are two different things. So, which is why one of the things I mentioned earlier is if you have Afib, that bothers me in hypertrophic cardiomyopathy more than anything else, for the simple reason that I know you're going to be more symptomatic, and I know it's going to be a lot more difficult to cure. And to me, if you have Afib, if you are starting to have symptoms, and as I'm walking into a room, I am praying, please God, let me find outflow tract obstruction in this person, because then I know what the heck to do with you. Send you for an operation, okay, which gives me a chance to fix you and make you feel better. Short of that, you are then doodling around with medications that may or may not work.
Okay, so now we're going to pivot to a question that I don't know the answer to or how you're going to address this. And Teresa's asking us, and I'm going to guess we're talking about CBD here. Is there any data on 10 milligrams of hemp for sleep or CBD oil for sleep? Have we done any data collection on use of CBD?
I think in these COVID time, Dr. Lever is doing intensive work in learning more about hemp and marijuana and hokum. No, I'm joking. He's not. He would
It's
kill me
not.
for that. I'm just messing with you. No. So, it makes intuitive sense. I personally do not have experience in this arena of research. I'm not. There's not much written about this. Now, the way I look at it, the HOCM, the O piece is the crucial part, the obstructive piece. Okay, so all these drugs, any drug that can affect your preload and your afterload. What do I mean by that? Think of your aorta and your outflow tract as a pipe. If there's obstruction in the middle of it, and if you are changing the pressure on the other side, which is what I call afterload, then it will make the gradient worse. Okay, so if you are hypothetically, and again, I am reaching here, but if you are well hydrated, if you are not changing sudden positions quickly, if the temperature is not hot, humid, what have you, and you want to take something to sleep because you are in pain or you have back problem or what have you, if you do appropriate lifestyle modifications for the obstructive piece of HCM, then there may be a role for it. We are living in the 21st century, so I'm not going, but it has to be individualized, and your providing physician needs to know, and you, the patient, needs to know exactly what your gradients are, what your obstruction is. I mean, you don't want to, hey, I was high and then I passed out and I have no idea what happened, and it may have been my outflow tract gradient, it may have been my hemp.
So I do have a funny story here. And this is a post-transplant story. So I did not have HCM at the time. I was in California about a year ago. And I went across the street from my hotel to a deli, which was a deli liquor store type place. And I went to the drink section. I just wanted some water for my room. And there was a basil something water. Mm-hmm. And I said, oh, that sounds yummy. And it sounds something like Lisa would like. So I grabbed the bottle of basil mint or something water, took it back to my room, drank 3/4 of it, and got really, really tired and slept like the dead. And in the morning, I'm like, wow, I slept fantastic last night. What? It must be the hotel bed. Then I looked at the bottle. It had CBD in it. And it was like, there was 2 servings in the bottle. So I probably had 15 milligrams of CBD. I slept like the dead. I have no idea what the implications to my heart were. I felt okay. But there was no psychological, like, I'm going to fall asleep now because I'm drinking CBD. I had no idea I did it, which makes me really worry about buying drinks in liquor stores in California. Read the label. Read the label.
No, I mean, look, again, everything. So, you more so the obstructed HCM patients, they need to be careful about what they do in terms of activities and sudden change in position, foods they eat, how much they eat, and but everything done in moderation, in conjunction with your physicians and knowing what you are getting yourself into. I mean, hey, this is a study that sooner than later is bound to happen.
We have done a query of the HCM population to see how many of them are using not only CBD, but any type of cannabis-based product. And I was surprised that of the 400 and some odd respondents, 35% are actively using, whether their state has it legal or not. Many of them are claiming that they have improved quality of life due to anxiety suppression from the products. I don't know what it's doing to their hearts. I don't know what it's doing to their lungs. But of those who are using it, less than 20% are openly telling their HCM physicians about their utilization. So I think it's time that we all grow up and we say, this is what I'm doing. And it's about time that the laws caught up with us. If alcohol is legal and safe, I suspect in no time the cannabis industry is probably going to grow in the United States, but we need to understand what it's doing to us.
Well, I mean, perhaps HCMA as a forum might be the right place, like an anonymous survey kind of a thing.
Yeah, we launched it a while ago out of curiosity because I was getting a lot of questions. And we ask if you vape it, you smoke it, you eat it, how are you ingesting it? Have you ever, of the have you evers, it's closer to 85% have ever utilized.
Yeah.
A certain percentage didn't like how they felt, so they don't do it anymore, but about 35% are actively utilizing.
Yeah.
I will just ask one other question or just give a follow-up. Can radiofrequency ablation be used to reduce gradient? And the answer is no.
No.
That's not what it's used for.
No.
So we have been chatting for a really long time. Milind, this might be one of the longest chats we've done, but it's been very engaging, and your sense of humor is like really refreshing. I think you're a Jersey guy deep down there inside. I'm not sure. See that sass. So I want to thank you for joining us today, and this will be put up on the Facebook, or we're on Facebook now, but it will be put on our YouTube page, our website, and this will also be turned into a podcast for Tales from the Heart, which is now available on Apple and Spotify. So you can download us there. And right now there's 2 episodes out, but there will be more coming very, very soon. So you can hear all things HCM all the time. Lynn, thank you so much. And thank you all for joining us.
Thank you for having me here. It was really a pleasure. I didn't even realize it's been an hour and 15 minutes.
I know. We've been going.
So this is awesome. Thank you so much. And hopefully it was helpful during this stressful time. Everybody stay safe. That's all I can say. All right?
Absolutely. Thank you.
Take care, guys.